So today's talk we're going to be focusing on the journey from Alma Alta to the Astana Declaration, and then towards universal health coverage, and how do we build a strong foundation for primary health care. I think that there has been a lot of excitement around the world, in many countries, at the subnational, national, and international level for universal health coverage, as many countries after the UN General Assembly in 2019 has committed to the political declaration towards universal health coverage by 2030. And we all feel that the best way to do that is to build a strong foundation for primary health care. So this talk really looks at looking back to the Declaration of Alma Alta to understand the challenges and the opportunities that the Declaration of Alma Alta presented to us, and then how we can learn from that to think about a way forward. So first off, regarding conflicts of interest, I do receive some funding from pharmaceutical companies, most notably from Novartis, for a strengthening primary care systems project. The objectives of this is, after my presentation, which will hopefully be around 25 minutes to 30 minutes, participants will obtain an overview of the evolution of primary healthcare policy from Alma Alta to Astana, have an understanding of the challenges, threats, and opportunities in building a strong and robust primary care system, and then really understand the current landscape in primary care health systems design. So to review, Alma Alta, the declaration came in 1978, and it came from during a very interesting time because it was at the height of the Cold War. And so all the country governments came together, and despite it being the height of the Cold War, to really commit to healthcare, and specifically primary healthcare. And the declaration really stated, very progressive for its time, saying that health is a state of complete physical, mental, and social well-being, and it is a fundamental human right. Here we see, kind of, not for the first time, but for the first time on the global stage, health not only being seen as a physical aspect, but also as a mental and social aspect. And the later criticisms of Alma Alta would say that this is too broad. And we'll discuss that in subsequent slides. But here, Alma Alta was very, very revolutionary for its time by guaranteeing that health is a fundamental human right. And they set a timetable to say, to accomplish this, to accomplish health for all, they wanted to accomplish this by the year 2000, which, now that we're sitting in 2020, 2 decades after the year 2000, we see that this was not accomplished, but we're still working towards that. However, despite that, I want to take some time to highlight some really great examples of how the Declaration of Alma Alta in 1978 was realized. So the first example is from Cuba, where we have the community-oriented primary healthcare system. This unique system features, at the rural level, a doctor and a nurse team caring for a group of community members. This is a very similar program to the Brazil Family Medicine Program, and that program was launched in it was enshrined in the Constitution of Brazil in 1988. And it was also kind of a team-based care model where we have a nurse, a doctor, and then 6 community health workers, each covering an area of 3,000 to 4,000 people, and each community health worker taking care of about 150 families. And this has really helped Brazil meet its population development goals in terms of meeting the health indicators in the MDGs, because this model is most heavily featured in the rural health system. Then we have the Pakistan Lady Health Workers Program, which is very similar to the Brazil program, where lady health workers were embedded within primary healthcare facilities, and they were trained by the primary healthcare facility, and they served around 1,000 individuals per lady health workers. And an external evaluation of the program done in the year 2000 by the World Bank with a community that had a lady health worker in it and a community that did not have a lady health worker in it saw that there were substantially better health indicators found for the control population, those with the better health indicators found for communities with the lady health workers in it. So we really see the value of community health workers working in collaboration with the health authorities. The nice part about the Pakistan program is that these community health workers were funded and they were paid a stipend. In India, we saw also another set of community health workers that were sponsored by the government, focusing on maternal and child health in the 0 to 6 age group, started in 1975 as a part of the Integrated Child Development Services program to look at the integrated development of a child. And that had a lot of good outcomes. And then finally, in Chile, we have the Chile Grows With You program that was launched in the early 2000s to really cover children from the ages of 0 to 4 to help, and also during the prenatal period. And the unique thing about this program is it did not only look at health, but it also looked at education and development as well. So it was a collaboration between the Ministry of Health, the Ministry of Social Affairs, and the Ministry of Education to really look at all of these, to really take an intersectoral approach. So even despite what we hear about Alma Alta not living up to its promise, we see from these 5 examples, but also from there are many other examples in the world that say that the Alma Alta Declaration did have a profound impact on the health of the world and of communities. So what were the challenges and the criticisms of actualizing Alma Alta? The first challenge was that the declaration was criticized for being too idealistic with an unrealistic timetable. And immediately in 1978, after the Alma Alta Declaration came out, the criticism was that because it was so broad, the idea of selective primary healthcare was introduced by Warner and Wash, which really said, okay, we can't focus on everything. So what are the most advantageous, most impactful things that we can focus on? And that, and so then we have the term selective primary care. Also during the 1980s, the decade after Alma Alta, there was a favoring of the privatization of public services, along with a loss of political commitment and a vision for implementing Alma Alta. And because of that, it really led to, contributed to a lot of the challenges. From the selective primary healthcare strategy theory came to be the decision to really focus on vertical strategies such as child nutrition, maternal mortality, malaria, TB, and then of course the HIV/AIDS epidemic. So really what happened were that parallel systems and parallel health systems were set up alongside the government health system to deal with these vertical diseases. So if you go to a community health center, they may have a program for HIV/AIDS, and they have a great program for malaria and tuberculosis. But if you came with hypertension, or if you came with just a diarrheal disease or something that wasn't in what we would call a specific vertical program, such as a national target program, the clinic would have a very low capacity to deal with it. And it also influenced the health workforce, because the health workforce was trained to implement these vertical disease strategy without thinking about the holistic picture of the patient. We see this juxtaposed with the last half century really seeing an immense growth in the biomedical discovery for preventing, diagnosing, and treating diseases. We have so much more types of drugs, classes of drugs to treat common diseases to rare diseases. And the biomedical advances have been so significant and so exponential. However, when we take a step back, we see that despite the biomedical advances, we have not had any advances or very limited advances in how we actually deliver healthcare and spread these advances to improve access, quality of care, and more equitable health outcomes. So this, I believe, is really the spirit of Astana that carries forward Alma Alta, is to think about how do we now deliver these biomedical advances and how do we deliver quality healthcare to everyone. So aside from that, we are living in a very different world than we were back in 1978. So now there is an understanding and there is political consensus around the need for universal health coverage, that healthcare is a right, and not a privilege. We have technology, we have devices at the tips of our fingers now, and in a lot of parts of the world, it's connected via internet, via 3G, 4G, 5G even. So we have that to help us with getting with increasing access to healthcare. There's a lot more biomedical advancements now. However, there's rapidly increasing inequity, both within countries and then between countries. We also have the challenge of disease patterns and demographic patterns with an older population and a disease pattern from communicable diseases to non-communicable diseases. We're also faced with climate change, social unrest, global migration is a huge issue. When one person, say a person is from Bangladesh, but now they're working in Kuala Lumpur, where do they get their healthcare and who is in charge of their healthcare? These are some of the very challenging questions in our very complex world today. And then we're also beginning to realize the evolving role of governments. So back in 1978 with Alma Alta, the understanding was that government would be the deliverer of healthcare and government would be the regulator of healthcare and government would provide services. But now we see a very diverse and very active private sector, community-based organizations, INGOs, etc., who are also in the delivering of healthcare market or who are also trying to advance the healthcare system. So we need to find a new way of working together. There's also a changing paradigm. So like I talked about, the disease burden, we're looking at going from acute to chronic life course. The health system orientation, it used to be that people would be sick and they would come to receive healthcare. So it was a react and a rescue, and it would be curative. And now we want to engage and empower our patients to have, to do health promotion rather than just health, just to treat. And then also to do prevention as well. We know that with the change in disease patterns to more non-communicable diseases, that the best interventions are actually the health promotion and health prevention stage rather than the curative stage. And then we were going from a fragmented episodic care. People only sought care when they were sick. Today they would go to the clinic, tomorrow they could go to the hospital, and the patient was moving. To now what we're looking at is a comprehensive, efficient, convenient model of care for patients. So how do the patients receive their care all in one place or coordinated all in one system that's efficient? And then when we look at behavioral economics, it needs to be convenient for patients. Patients need to have, or people need to have access to it and have it be readily available to them. And this is where the role of technology can come in. And then finally, the role of the patient. So it used to be a person who is passive, who will go and present a problem to the healthcare system, and then they would receive information back and then be told what to do. And now we're looking at patients who are more empowered, who are more knowledgeable, who have more access to information. So now they're more active, and we want these patients to be active in their care. So this is also the changing paradigm shift that is different between the Alma Alta era in 1978 and now what we have today in 2020. And then there's this idea of, because we have to look at people in a holistic manner, we have to think about promoting health through the life course. So looking at health from the prenatal period, and all the way through geriatric care. So how do we develop a holistic strategy to optimize people's health and well-being throughout their life? And we want to focus on human capital here. So human capital is just another fancy term to say, how do we allow the healthcare system to enable people to live to the best of their potential, to be able to be the most productive members of society? Because we know that by citizens or people who are able to be the most productive members of society, they can contribute to society, and that drives economic growth and drives socio-economic development and sustainable development. So we need to look at the entire well-being of a person through their entire life, not just when they're sick. So we need to focus on a well care system, not just a sick care system. And if we reframe the thinking of how to develop healthcare systems into this kind of life approach, then it forces national governments and those working at interventions to to think about it at the systems level and think about the interlinkages between the life stage. So we focus on pediatric and child health and how we can grow and nurture that child to be healthy, to have lifelong healthy habits, to become an adolescent, and then to become, whether it's a factory worker or whether it's to go to college or university and then onwards to adult life. How do we keep them healthy at all the life stages, and what are the specific interventions and the and the prevention aspects, from vaccinations to cancer screening? What are the interlinkages between the life stage? And this takes a multi-sectoral approach and action. So we see that the government of Chile has begun to do that with with creating the Chile Grows With You program that I talked about earlier, where it's a collaboration between the Ministry of Health, the Ministry of Education, and the Ministry of Social Affairs to think about children from the time that before they were born until 4 years old, and now Chile is expanding it until the time the children are 9 years old. And then it helps further clarify for us what it means to be integrated people-centered health services. So we've been throwing the term around a lot: people-centered healthcare, patient-centered healthcare. What does that really mean? And if we look at the life course approach, we have to see that we have to think about all the stages of life. And that's another way to help us think about how to make our healthcare system very people-centered. So this is the WHO schematic for what the life phases are, and how we think about this. And this can be available through the WHO website, from promoting health through the life course. And this is a very new idea of thinking at the international level. So this takes us to the Declaration of Astana in 2018. And the Declaration of Astana really said, the declaration affirmed to meet all people's needs through the life course through comprehensive, preventative, promotive, curative, rehabilitative services, and palliative care. So really looking at all different types of care, not just the curative care that we are focusing on, and focusing on also for the first time palliative care as well. And finally, recommitting that healthcare is a fundamental right of every human being in the world without any kind of distinction. So this is a very lofty goal, so I'll break it down a little bit. So the commitments of Astana are: one, to make bold political choices for healthcare across all sectors. So what this means is promoting and protecting the right of everyone to the enjoyment of the highest attainable health standards. So allowing people to be their most active and productive at every single stage of life, and to really promote multi-sectoral action for primary care and for universal healthcare, engaging with all different types of stakeholders. This requires commitment from the political level. And that it is saying that we want to make bold political choices to say that health for all, where we're not leaving anyone behind. The second commitment is to build sustainable primary care systems. So that looks into infrastructure and capacity. It looks into a comprehensive set of care to go away from the selective primary care and to go away from national target programs, and to make sure that primary care is accessible, equitable, safe, high quality, and efficient and available. The third commitment is to empower individuals and communities. We saw this already in a previous slide, where patients and our communities have more access to information, and with information comes empowerment. So how do we engage patients and engage communities to keep themselves healthy? And that's the key here, is to really keep healthy, keep communities and people healthy to prevent them from getting sick. And then finally, commitment 4 is to align stakeholder support to national policy, strategies, and plans. So really partnering with national governments to empower national governments and work with them to create a primary care strategy and plan, and then to make sure that all development partners and also all private sector partners, community-based organizations are not off doing their own thing, but rather contributing to the implementation of that policy, the national policy. So I think that, again, these are really bold commitments, and we're going to dive deeper into what that means. But before we do that, just to take you through more of what happened after Astana. So after Astana, then in May of 2019, the World Health Assembly met, and the World Health Assembly is where all the ministers of health of member states, of UN member states, joined together, and they came out with a declaration or a commitment to primary healthcare, and to say that they support the vision that was set out in the Declaration of Astana. Following that, or around that same period of time, the G7, so the 7 largest economies of the world, met, and they also committed to saying that primary healthcare is a cornerstone for sustainable health systems development in order to help with the sustainable development goals and to reduce inequities. And finally, this all accumulated in September 23, 2019 in New York at the UN General Assembly, where there was a high-level meeting for universal health coverage, which in the political declaration recognizes the important role of primary care and the critical role of primary care, and how to, and to build and to invest in strong primary care systems in order to achieve universal health coverage. So PHC, or primary healthcare, supports universal health coverage and the sustainable development goals by mostly focusing on SDG 3, which is good health and well-being. But if you look at the other 17 sustainable development goals, we see that it supports actually all of it. So not just SDG 3, but it with good primary care, we can alleviate poverty, we can alleviate hunger, there can be gender equity, clean water, reduce inequities, intersectoral collaboration, et cetera, et cetera. So, so having a primary care first strategy really allows for country governments to achieve universal health coverage, but also to achieve the sustainable development goals. So how do we get from declaration and political commitments to implementation? And this is where we have 3 really great guiding principles from the UN agencies. So the first one is the global strategy for women and children and adolescents health. The second one is the vision for primary care in the 21st century. And the third one is the operational framework, transforming vision into action for primary care. I just want to note that this operational framework has not been finalized yet. It's still in draft form. So focusing on the operational framework, it has 3 areas: multi-sectoral policy and action, empowerment of people and communities, and then the essential functions of integrated health services through primary care. So the framework is separated into levers of action. So there are the levers of actions that we see here. So everything from political commitment and leadership, governance and policy frameworks, to medicines, physical infrastructure, workforce, models of care. And this framework really goes into detail about what needs to be, what are the inputs that are needed to be in each of these levers of actions, and then also how to measure it for country governments and development partners to consider when they are developing primary care strategies. Another very notable area is measurement. So how do we know that we're delivering good primary care, and how do we know that we are working towards good primary care systems? So the Primary Healthcare Performance Initiative that's led by Beth Tritter, who, and it's a collaboration between the Bill and Melinda Gates Foundation, the World Bank, the World Health Organization. They have put out this primary care vital signs profiles and are encouraging and working with country governments to create a primary healthcare vital signs profile for each country, so that at a glance we can see how does each country perform on financing, on capacity, on performance, on equity, based on the country context. And this allows development partners, it allows NGOs, and it also allows the government to see where the areas that need more investment, where the areas that need more focus, to give technical assistance and investment to. So this is an example from the Kenyan Ministry of Health and the Kenya profile at a glance. You see that not everything is completely filled out, but for example, with PHC spending, we can see at a glance that Kenya spends about $40 per person, and 50% of their overall health spending is on primary health care. And we have a performance index for Kenya and an equity index. So the hope is that the idea of measurement and measurement for action, such as the vital signs profile, can be more popularized, and so that more people and more country governments, or even subnational level, can do this, so then people can look at it and it's transparent, so that we know the areas of intervention to allow us to achieve universal health coverage through primary care by 2030. And then the last aspect I want to touch on is this idea of partnerships, because we know right now that it is that governments are very limited both in their resource, but also in their technical capacity, that they can't, there's no government in the world that can cover every single aspect of healthcare delivery and primary care well. And so there needs to be partnerships. So how do we create partnerships with meaningful engagement from a diverse group of stakeholders, which means government, private sectors, patients and communities, civil societies, and academia, to design primary care systems and strategies and interventions? An example of one that is currently operating right now is in Vietnam. We have the Technical Working Group for Primary Healthcare Strengthening, which is a public-private academic collaboration to think about how to implement the Vietnam health strategy, but also how to implement the primary healthcare strategy, and where is the needs for the different types of technical assistance, but also financial and resource to all tie into the national plan. And then, so a little plug in the last couple of slides for my program, which is the program at Harvard Medical School in Global Primary Care and Social Change. So our goal is to help with this effort and to play a catalytic role in the global effort to achieve universal health coverage. And we do this by 5 areas. So we want to be able to work with governments and other region and subnational regions to scale innovations. We think that there needs to be new innovative types of care delivery models, whether that's virtual care delivery or physical care delivery or an integrated platform, and then to take it out of pilot site, but to scale it. We think that there needs to be future leaders in primary care, and we need to train those leaders and train current leaders to develop new partnership models, the new public-private partnership models that I was talking about, and then to connect communities and governments together in these learning collaboratives to share best practices and experience. And then throughout all of these 4 work streams, the 5th work stream for us is to generate more knowledge on how we work together in these 4 work streams to promote this vision of UHC by 2030 via primary healthcare strengthening and transformation. So I just want to say thank you. These slides, some of them were borrowed or slightly modified from colleagues at the World Health Organization, at the Primary Healthcare Performance Initiative, at the Kenyan Ministry of Health, and from the Primary Care 2030 group, which Harvard convenes every year. The last 2 years was in Dubai. So with that, I will say thank you, and this is how you can contact me on Twitter and also on email. Okay.
Thanks, David. I've got some questions that I'm going to be asking you, but I encourage everyone else that is joining online to feel free to chat through questions. There should be a chat button right about here-ish on your Zoom screen. So feel free to chat some questions. We'll ask them on your behalf as well for answers and conversation right now. So I'm going to start with my first question. What do you see as the key challenges for countries transitioning to UHC? And are these the same or different than those facing the challenges in the US?
So I think the key challenge, like we talked about, is that a lot of country governments, and especially in low and middle income countries right now, their health systems, especially at the primary care level, are based on national targeted programs. So selective care, so a diabetes program, a malaria program, a tuberculosis program, a child health program, a malnutrition program, etc. And what we ideally want to do is to horizontally integrate all of these programs into what we would just consider a basic package of services for primary healthcare delivery, where a person can come to the clinic and say, I have a cough, or I'm here for my vaccinations, or whatever, and then then they have a patient record, and they're not in a particular program. They're just being taken care of at that clinic, and these programs are already integrated across all levels. The second aspect is how to pay for this. And this is where health insurance comes in. So whether your country is a public model, a private model, a mixed model, is how do we pay for these programs? And we know from evidence that primary care services are cheaper, more effective than hospital-based care. So how do we build the business study or the business case study for country governments that are currently either paying at the hospital level only, or that are paying for these national target programs, but not for general primary care? How do we build the business case study for them to say that it's more efficient for that local area? In the United States, it's a little bit different, because we are facing different challenges in terms of integration of our health networks, of our electronic health records, etc. And we don't function so much on the vertical programming model. So that's a difference from the United States.
I'm adding an additional bit to that question from the chat. What do you think is the most challenging thing in Vietnam?
So in Vietnam in particular, and I'm not going to say that I'm an expert in Vietnam, I've spent a lot of time researching there and working with the government, is I think the idea of integrating in the national target programs and to horizontally integrate it all together, and then also paying for it. So incorporating those services into the social health insurance. And then the other challenge in Vietnam that we see is the capacity of health workers being able to deal with all of this stuff.
So I have another question from the chat. Can you talk more about how you teach students about social change, including grassroots advocacy, political lobbying, and what models of change are exemplary given the domestic and international scope of these problems?
Yeah, that's an excellent question. I think that social change, if we look at any of the social movements, really comes from the students. And I think that as a student, you have a lot of time to devote to these to different causes, and that you can be very vocal as well. So I think that in terms of what students can do and how we can teach it, I think that for health professional students, working at community health centers or volunteering at them, volunteering at community-based organizations is a good way to get your feet wet, but also a good way to understand what are the issues that need to be raised at the political level, what are the issues that need to be raised up that you see at the community, and then really being an advocate and a voice for the communities that you are embedded in and that you are part of. I just think, and I would advocate for students, given the time and the energy that you have, is to embed yourself with a community organization and learn from that. I think that these models are different in different international contexts, just given the different political nature of different country governments and different regions. So political action may be different in the U.S. than it is, say, in Thailand, say it is in Cambodia, say it's in Kenya. So you have to work with whatever is most contextually appropriate. But again, I think that the recommendation of embedding yourself or working or volunteering in a community-based organization to understand the challenges of the community will help you gain very useful skills to then advocate for those communities.
Thank you. What is your advice for staying engaged despite significant system barriers?
I think staying engaged, I think that it's something that happens to all of us. The bureaucracy and systems are set up to help us function and to help give rules and norms. However, they can also kind of burden us down. I think that to stay engaged, you have to find a cause that you are very excited about. You have to find a community, and it has to link back to the personal, right? So for me, what drives the work that I do is I think about my patients that I met during when I was in medical school, or even before medical school when I was in the villages in Vietnam doing my nutrition studies. And I think about the people there, and I think about the stories that they shared with me and the challenges that they faced, and then how I can help work on the systems level issue given my position now. So I think that the motivation and the drive and the passion comes from personal stories. So how do you create opportunities for you to cultivate those personal stories that then become, that then are the fuel for your passion and your drive?
Got another question from the chat. What events or conferences do you or the center or Harvard have planned for India in the coming year, considering the promise and scale of Indian healthcare?
So Indian healthcare right now is so prominent on the world stage because of the ambitious vision of your government with Modi Care. The Center for Primary Care would love to engage with India. We currently do not have any active collaborations in India right now, but if there are opportunities, please reach out to us. We would love to research the study and to be involved in the movement to help India achieve high quality healthcare for all. I know that my colleagues in the School of Public Health at Ariadne Labs has collaborations in India. That they have some small scale, they have some projects on. Other than that, I don't know if there's anything formal that Harvard is engaged with India in terms of healthcare right now, but we would love to get involved.
Here's another one from the chat. Can you share your observations and experience on how primary healthcare systems are helping to increase access to medication in Vietnam?
Right. So my observation is that right now, if we look at the Vietnamese healthcare system and what medications are available at the primary care level, the good thing is there is medication available at the primary care level. Now, there is a question, I think, of quality and of quantity, and then of also of choice, meaning more than one type of class of medication. So as we build a more robust primary healthcare system, we can increase patient engagement with the primary healthcare system in Vietnam. And by increasing patient engagement with primary healthcare in Vietnam alone, that will help get more medications to the primary care level because the need will be driven up. Also, if we increase it in a way where patients are feeling empowered and they have knowledge, then what happens is patients will, I think, demand more more quality, more types of medications, and then providers will also be more comfortable with keeping those on stock. So that will also drive up access to medication at the primary care level.
So another one from the chat, we talked a little bit about some of the challenges facing the transition to universal health coverage. What will it take for the US to achieve universal health coverage, and how do you see that happening?
That's a very big question. That's a really big question, but I really appreciate you asking it. And this is what we need to be asking, I think, not just in the US, specifically in the US for this time period, given this is our election year, but also around the world, is basically we need to have a movement, a local grassroots domestic movement, whether you're in rural America or whether you are in urban and city cosmopolitan America, to say everyone deserves healthcare and everyone deserves the right to healthcare, and really pressure our policy leaders to say that. Because right now the question is it Medicare for all? Is it selective Medicare? Is it private health insurance, public health insurance? But I think that doesn't really get into that aspect of healthcare as a fundamental human right, and we really need to kind of continue to push that forward. So I think that it's really going to take education of the public is one, and grassroots movement, and it can't just be happening at the cities and in academic areas. It needs to be happening, the conversations also need to be happening in the rural areas as well.
Thank you. I've got a related question, and this actually comes from a previous S.C.O.P.E session that we've led on climate change and that as a driver to public health. How do you recommend advising patients who seek guidance on policy issues related to their own health and also to healthcare at large? And the reason I'm asking this is because our previous speaker shared some data about how primary healthcare providers were actually listed as one of the most trusted resources when making decisions, not only about health, but about kind of larger policy and issues affecting day-to-day life. So I'd love to just kind of have you comment on how you might advise a patient who's asking for your advice.
On policy.
On policy, yes.
So you can all see here, so I have a pin, I'll show it to you. This is the US Census 2020, and I wear this every day, and especially on the days that I'm in clinic, because I think that patients and people who come to see me in clinic and my primary care clinics are the best advocates, not only for their healthcare, but also as advocates for the entire health system in general. So, for example, talking to patients about the importance of participating in the census, talking with patients about the importance of voting, talking with patients to say, you know, you are very lucky to have a primary care provider that you can call and that you can talk to. Not everyone is so lucky. So how do you think we need to change that? And I think that again, it goes back to the personal stories, and it goes back to the patient sharing their personal experiences with primary care and how it's helping them live their most productive lives, to policymakers, that writing op-eds about it, etc. That really, then I think will promote change and will promote policy change. I just want to revisit one more point back to the last question about what it's going to take to achieve universal health coverage in the US. We spend trillions of dollars a year on defense. We spend trillions of dollars a year on other aspects of our federal budget. We can afford to have primary health care for all if this is a national priority for the country. And the only way that it's going to be a national priority is if voters make it a national priority. So we do need a grassroots movement for this, because to all the politicians who say it's too expensive, we can't afford it, well, we are affording a lot of other things that are much more expensive.
Thank you. And we haven't had any questions in the chat lately, so I'm gonna pose with one question, one final question from me, and then if there are more from the chat, we can share those. But what's one takeaway you'd like people to have from this session?
The one takeaway is that there is now a global movement for universal health coverage and via primary care. So please know that, and become an advocate for us, and that healthcare is a human right, and that we have a second opportunity after the Alma Alta in 1978. Now we have Astana, and we have the UN political declaration to make this a reality. So please, you know, do what you can in your community, big or small, to help push forth this mission.
All right, so I did have one more question come through the chat, and it's asking for examples of other countries that have successfully transitioned from heavily meritocratic, structurally inequitable systems, capital societies, health systems built around insurance companies that have transitioned to achieve universal health care, and if there are examples and kind of roadmaps to that for a grassroots movement in America that might require a significant fundamental shift.
A very hard question. I don't know off the top of my mind if there is a good example that is basically what America is, and then what we should transition to. I'll have to get back to you on that. So feel free to email me. It's a very good question, but I don't have an example of that.
That's fair. All right. Well, if those are the last questions, I'd like to thank everyone for their attendance and for being so involved in the chat and for great questions. I'm so excited everyone could join us for this session. Special thanks to Dr. Duong for sharing his time and expertise, to our team at the center, especially Megan Lenneman, who is slightly off screen, but who has done all the work to coordinate the session. I'd like to remind folks that this webinar has been recorded and will be archived on our website, so please share with colleagues, revisit as you see fit. Our next S.C.O.P.E webinar is at noon on April 3rd, and that will focus on social determinants of health and food insecurity. So we'd love to have you back to join us. You'll see a follow-up email with more information. I'd also like to highlight that the center is running a Medical Director Leadership Institute, which takes place on May 14th through the 16th. You can find out more about this program and about the other work that we're doing, including Dr. Duong's portfolio of work, by visiting the center's website, which is primarycare.hms.harvard.edu. And we can share more info about that in a follow-up email as well. I see someone asking if we can get the slides, so we'll follow up with that as well, and hopefully Dr. Duong would be willing to share some version of the slides that he shared earlier today. But thank you all for joining. Thank you, Dr. Duong, for your participation. And we hope to see you at our, sorry for the traffic outside, and we hope to see you at our next seminar. So thanks very much for joining, and we're gonna log off now.